Okay, afternoon, folks. Just gone 12:30, so good to see you on the call, and welcome to this week's report out. So we've got three presentations this morning. Looking forward to hearing back from Dominique and Adele about their timely imaging transfers. Now the 60-day report out, and then we've got Nicola talking about improving experience for junior doctors, and then Tom around the MISPERS criteria-led pathway. So we'll go through each presentation one after the other, as we always do, and do Q&A at the end. So I'll hand straight to Dominique and Adele, I think. Can I see you on the call? Yes, Cam. Hi.
Thank you, Phil. Good afternoon, everybody. This is the 60-day report out for the timely imaging transfers. My name's Dominique Parker. I'm the Facilities Operational Manager for Portering, and we're joined on the call by the other process owner, Adele Clark, who is the ultrasound team manager. The RPIW was held at the end of April to look at how we can improve the efficiency of the inpatient journey to and from Chancellor Wing X-ray and ultrasound. So just a brief recap of why the RPIW was held. We were receiving an influx of imaging requests at the end of the doctor's ward round, which caused a batching. And this batching resulted in multiple patients being requested on CAPS at the same time, which caused backlogs in the portering system, a significant waste of resources for the radiographer and the sonographer, and also a cost and flow implication. Next slide, please. So the actions that came from the RPIW, the PDSAs, were the golden patient and the transfer team, which I'm going to give you an update on in the next couple of slides. Another PDSA was that X-ray were calling the wards in advance to the porters going there to collect the patient, to verify that the details were still correct, that the mode of transportation was the same, and that nothing had changed with the patient. For example, they were now source isolation or required oxygen. And in order to do that, we provided a nurse in charge phone, which was a dedicated phone line in order to get that information. With regards to portering equipment, we entered recurring tasks on CAPS to complete area clearances to ensure that that equipment was available for the porters when they needed it. And ultrasound created 2 vetting slots at 8 AM and 1 PM to ensure that all of the requests that were coming through were vetted and that they were valid and justified. Next slide, please. So with regards to the batching, the top left-hand graph there shows the tasks from 2023, and that blue line depicts the demand that's coming through, and we can see that there's a huge spike there at 10 AM and at 2 PM. So in order to spread that out across the other hours of the day, we introduced the golden patient, whereby the doctors were booking that first patient, patient's image in flow, and then seeing if they could do that with patients that followed. So J12 has done this from the start and continue to do so, and we've just started with J84 trialling that, and we'll be able to give you an update on that on the 90-day report out. Feedback from the ward staff has been great, and they've been on board, which has been great. On the right-hand side here is a heat map which shows 8 weeks of data from the workshop, and then the same 8 weeks from 2023. And we can see that that 10 AM and that 2 PM peak has reduced significantly. However, we do seem to have now created a peak at 6 PM, which is something that we're going to look into and look to remove and resolve before the next report out. So the transfer team, the initial idea of the transfer team was to have a clinical support worker working with the porter to go and collect patients for radiology, and that clinical support worker was there to assist the porter to get the patient ready, help with the pat sliding, which freed up the ward staff to continue doing their activities. We decided to take a different approach since the last report out, and we looked at patient flow. We was working with the CSM, who was focusing our resources and prioritising our workload, and we were helping with ED breaches, looking at that patient's pathway, getting patients to the discharge lounge, arranging the clean of that bed space ready for the next patient to come through, to see how we could improve that flow, given the current challenges that the organisation is under at the minute. Highlight some communication issues. For example, we were reacting very quickly, we were responding in far less time, which meant that some of the wards were not necessarily prepared for us. That's something that we're going to look at before the next test of change. And although this isn't regarding the radiology tasks, which is why the RPIW was held, it does directly link back into radiology because, for example, the CSW and the porter were completing bed jobs together, which would ordinarily be done by 2 porters. So it was freeing up that resource of an additional porter to complete the other work that was going on in the hospital at the time. So the target progress report, looking at the lead time, which is from the doctor requesting the image right up until the patient having the image and being returned back to the ward, we can see that we've made a 36% improvement for X-ray and a 13% improvement for ultrasound. With regards to the sub-lead time, this is the transfer team. So we've gone from 26 minutes right down to 18 minutes. This is, however, a slight increase from last report out, but this is due to the communication issues, which, like I say, we're looking at how we can resolve that, and we will hopefully see this time reduce even further in the next report out. The quality defects is looking at the number of delays that the porters were experiencing. So it initially sat at 17.79%. This is reduced by a huge 40% and we're down to 10.7%. This is just from contacting the wards, making sure that the patient's ready and that we do have all the relevant information. With regards to the amount of tasks that are taking more than 30 minutes to be allocated, the baseline sits at 25.77 and we're currently at 27.73. The reason for this is the sample size. The baseline is for the number of tasks that were completed throughout 2023, whereas we're looking at just 693 jobs. If it was the same sample size, we'd see an even bigger improvement. In terms of staff satisfaction, that's now increased by 11%. We've still a long way to go. And the patient satisfaction, we've increased from 7.87 to 8. We acknowledge that this is a drop from the last month's report out. However, this is again down to the sample size and we will look to increase that before the next report out. So what went well? Collaborative working and all sharing a common goal. Any ward, department, CSM, head of nursing that was involved in the test of change have all been engaged, enthusiastic and really helped us. The test of change for the transfer team has given us excellent intel and really looking at how we can support the organisation with the 7 commitments in terms of reducing the patient stay, the ED breaches. And we've also had a lot of data that we've had to analyse in the last month. I'm talking hundreds of thousands of tasks and looking at comparisons to see if what we are doing is really beneficial. Any improvement that we've made or any test of change we've done, none of us have lost the patient's perspective. Everything we do, we constantly ask ourselves, how will this improve the patient's experience, which is fantastic. And obviously the positive data results on the target progress report speak for themselves. We've continued that staff engagement with the huddles and the briefings, and we really rely on the staff to give us that feedback so that we can make sure the changes that we are making are also having a positive impact on them. So what would we do differently? We haven't upscaled the PDSAs as we intended to, and we have found that some of the PDSAs in the last month have been quite slow. The transfer team, for example, takes up a lot of our time. So this has meant that something else, such as the equipment, we haven't focused the same amount of attention on that. But we are looking for the next steps to introduce new staff members to support so we can continue the momentum for all of the PDSAs. We're going to be upscaling the PDSA with the golden patient. We've got meetings with respiratory to look if we can roll that out across all of the respiratory wards. And the nurse in charge phone, J50, has kindly agreed to support us with that moving forward. We're also going to tackle this 6 PM batching that we seem to have created and looking at how we can eradicate that. And we will continue to do more tests of change with the transfer team to see where the organisation will benefit from having a transfer team in place. Thanks ever so much for your time, and we look forward to giving you the 90-day report out next month.
Fantastic. Thank you, Dominique. Really good. And just really nice to hear about the patient focus through the whole thing there. So well done, and some really good reflections. So let's keep questions till the end. So we'll go straight on if we may. Hi, Nicola. Can we bring you in around improving experience for our juniors? Thank you.
Yes. So my name's Nicola Merkin. I'm the Senior Rota Coordinator for AMS. I'm here today to share my Leeds Improvement Method project that I've been working on since attending the LIM Intermediate course. My next slide, please. So my project was to improve doctors' rotation experience as a whole within AMS, following feedback from the juniors that there was issues with rotas being sent out late, inductions, improvements with training, whilst with their specialties just as a starter. As a CSU, we needed to make lots of improvements to retain our trainees and also to improve expenditure. So I needed to basically put together what I needed to in the project. When I started this project, I tried to contact the schools and the deaneries for the juniors' feedback. However, they were unable to release the information. So the first thing I had to do was get feedback from them myself. It then became apparent there was many aspects I needed to work on, so that I had to split this into different mini projects. I also had to try many different LIM methods like spaghetti diagrams, process flow charting, and just to find the best method to make these improvements. Next slide, please. So I sent out feedback forms. So on this slide, you'll see the example of the feedback forms that we used, just asking about different life events that the doctors may have coming up, if they were less than full time, so that we can plan the rotas around their life as well as obviously the department. Once we gathered the feedback, we also found that there was a delay in the rotas being sent out, which was a big issue. So this was where it became my first project, was to make these rotas more available within the 6-week deadline. So the knock-on effects were that we would be basically covering gaps for annual leave and life events that we couldn't work around. We also hold a bi-monthly feedback forum, which has helped the juniors come and raise the issues with us, with the service manager and the college tutor, and the juniors feel more heard and listened to about their different issues, and we're able to take away different aspects that we can improve, which has been very helpful. Myself and my manager meet up to discuss the issues and how we can improve the timings of the rota allocations, and from this we've produced a checklist so that we can keep on track with the timings. Next slide, please. So here is the spaghetti diagram, which shows the flow of how we used to get the stakeholder reports. They used to come from the deanery to medical staffing, then to medical deployment, and then to the department. So the timings were, obviously, we was getting them 9 weeks before rotation, and the doctors, by the time we could actually get feedback from the doctors with their life events, it was getting later and later. So we met with medical staffing and with med deployment and come to the conclusion that we could actually get them directly from med staffing rather than med deployment. We introduced a inbox so that information governance was covered. And then on this slide, you can see the difference in the weeks that we've made up. We are now being able to send the rotas out at least between 7 and 8 weeks before, just by missing that one step. And the feedback from the doctors just by doing this has been great, and it's actually helped towards our waste reduction on the locum spend and the use of agency doctors. Yes, as I said, the waste expenditure for locum spend, we're reviewing the gaps ahead of time. The deadlines are being met throughout. What went well? So I found the feedback forms and the forums worked really well, and it kept the juniors involved in any changes. They felt included in any changes and improved the relationships between us and them. And they also knew that they could rely on coming to my team and being able to be heard, rather than they didn't know who to report to and stuff like that. What I would do differently, so whilst I was working on this project, we did have team shortages, so I definitely would block out more time in my diary to work on the projects. Having time is vital when working through them, and it makes the improvements come in quicker, and it just will improve the time for the doctors as well. My next step is working on making the induction more robust and more streamlined for the doctors. We're currently having a plan with one of the SHOs joining us to help us improve what they want on the inductions, and also help with their handbook so that they can give their advice to the FY1s that are coming in that have never been in a hospital setting and since their medical student time. We're ensuring more communication between the teams has been a big issue, and making sure that we're getting the consultants and the leads all involved in all the management. Improving the gap management and process. We're revamping our weekly staffing meetings with medical deployment and introducing a production board so that we can be more ahead with the gaps that are coming through.
Fantastic. Thanks, Nicola. Really great piece of work, and I think focusing on one of our staff groups, really important to make sure we're contributing to that quality of life support that we can in terms of their work here. So that's really good. I'm sure there'll be some questions about that, but let's move on to Tom, if we could.
Hi everyone, thanks for having me. So my presentation is on a project I did whilst I was in corporate nursing, although I'm with KPO now as part of my intermediate course. So it was to improve the process and the pathway for missing patients at Leeds teaching hospitals, alongside collaborating with West Yorkshire Police and Yorkshire Ambulance Service to just improve the experience of the patient base. So as part of the biennial review that we did as part of my previous portfolio with the policies and procedures, we had the missing person pathway come to us. And as we started doing the review and engaging a wide stakeholder base of LTHT staff, including safeguarding, mental health, and then because it's a collaborative procedure, we also involved West Yorkshire Police. We would discover that there was huge discrepancies within the process that we were supposed to be following and what was actually being done, alongside confusions around RAG rating and grey areas, as it were, with the specific areas that we had. One of the challenges that we faced was the RAG rating system that we were implementing with the risk assessment tool that's in the middle there was extremely different to the one that West Yorkshire Police had. So a category of a high risk that we would say as a nursing team, this is a high risk patient that's disappeared from the trust, the police would have a completely different assessment for that. So they would immediately categorise that down, and we would end up in a sort of triangle of passing it between LTHT, West Yorkshire Police, Yorkshire Ambulance Service, and that wasted so much time, especially for the staff, but also if we've got a patient who's left the trust, putting them at more risk if we're not actually trying to actively find them, if we're stuck in a loop of phone calls. One of the other challenges that came up as well is we realised that the risk assessment that we were doing was actually at the end stage of the process rather than the beginning. So as a consequence of that, the patient had already gone missing. So it felt like it was too late to be doing that risk assessment, as we should have already been putting interventions in at the beginning stages of the process. The data that's shown on the right-hand side there is from a sample pool between April and September, where 123 patients were reported on Datex as going missing, and the process that was supposed to be followed was a risk assessment was supposed to be completed and attached to the Datex, and we found that only 2 of those in that sample pool had actually been done. So when we presented this at the heads of nursing, we could see there was huge discrepancy between the process that was actually being followed. So it was one of the things that we wanted to patch up and to make sure that as part of the policy review process, we were also implementing a new pathway for staff that was more helpful and helped us collaborate better with West Yorkshire Police. There was also discrepancies around what is an amber patient, as when we got stakeholder feedback, it became very apparent that if a patient has left the trust and they don't have capacity, they're immediately deemed a high risk, as they're not able to maintain their own environment. So again, that was one of the reasons we wanted to move away from this RAG rated system, with also matching it with the West Yorkshire Police one as well. So one of the PDSA cycles that we implemented was getting all of the stakeholder feedback from different CSUs and West Yorkshire Police and Yorkshire Ambulance Service, collecting all the data and collaborating in lots of meetings to discuss what are the criteria that we would want to implement for looking for that patient. It also came to light during this process whilst we were creating it that there wasn't any process in place or pathway for patients who had indwelling devices. So anyone who actually left the trust with a cannula or an NG tube, etc., there wasn't anything in the policy regards to that. And the process that we were following was just very verbal and informal to Yorkshire Ambulance Service to say, this patient has left the trust with this indwelling device. But as part of their categorisation of what patients they would go out and see, they would inevitably pass it back to us and say that that isn't something that they would deal with. So we wanted to make sure that we were equipping staff. So another PDSA cycle came out of that to test a new indwelling devices pathway that goes alongside the MISPERS pathway. And as you follow it, going through the criteria, it will then lead you to the new indwelling devices pathway. So utilising those PDSA cycles, it helps us create more clarity. And by moving away from the RAG rated system, it meant that we weren't using confusing RAG ratings that conflicted with West Yorkshire Police, but also with Yorkshire Ambulance Service. So by agreeing what criteria we wanted with safeguarding, mental health, West Yorkshire Police and Yorkshire Ambulance Service, we were able to agree on what the phone calls would be for. So we would end up getting more relevant phone calls to the more relevant services, because as we were pulling out the data, it became more apparent from the external inputters that we were giving them more inappropriate referrals than anyone in West Yorkshire. So that was something that we really wanted to deal with. Once we implemented these PDSA cycles, one of the measurements that we had is we used staff feedback to make sure that we measured what our baseline data was for using the original pathway to what it was to the new one. So the blue bars on the left-hand side, they're positive comments. So on the left-hand side, that's the original pathway that we were following. The red are negative comments towards the pathway, and the green are impartial, neutral to it. So we can see from the left-hand side, there was a significant improvement when we implemented our new pathway of positive feedback. And there was a lot of comments around feeling more empowered, especially from an MDT perspective of following a specific criteria so that they could escalate through the appropriate channels, and they felt there was less time wastage as well. We also wanted to look at measuring the success of it through the datexes and the security calls. So we found when we were speaking to security as part of our stakeholders that a more accurate representation of the how many patients actually go missing within the trust was based on the security reports, not the datexes. So another part of the process that was being broken down was a patient was going missing, but the datexes weren't being completed with it. So we were looking at security data to reinforce what we were doing. So a measurement that we wanted to see was, if we implemented this as part of a step within the criteria-led pathway opposed to the original RAG rated, would we be able to measure the success of how people are following the pathway? What we found is that from St James's, although there are still discrepancies between the security calls and the datexes, there was 20% of the datexes in 2023, and we've gone up to 39%, represented by the green bar there. So an increase in matching security calls to datexes. And from LGI, we found that there was a 10% in the original to 52%. So we were really pleased with the results. So we had really positive staff feedback. We could see that the pathway was being followed by measuring security calls to datexes, and that keeps going up, and we've been measuring it using the datex system. So really pleased with that, and it seems to be getting good feedback, and we've had less inappropriate referrals deemed by West Yorkshire Police than we had in the previous year as well. So really pleased with that. Some of the things that have gone well with it is by doing the Leeds improvement method approach of having people on the ground floor at the grassroots making those changes rather than us doing it to them, we had really good engagement from a really wide variety of CSUs who were able to give that input into this pathway. So the collaborative approach that we had was really a testament of Leeds improvement method, which was fantastic and really pleased to see. We were also, because of the indwelling devices pathway, able to get better patient feedback, although it was an end-step process and it's hard to survey patients that have gone absent from the trust by their choice or if they're confused. We found that we were having a much more positive impact on the patient base because we were able to communicate with them through more appropriate channels and actually get checks on them if we did have those concerns. And also we've been nominated for a HSJ and shortlisted as part of this project for the success that it's had. So really pleased with that. Yeah, thank you very much. So one of the things that I would do differently, so now that I am in KPO and actually have a deeper understanding of the Leeds improvement method, I would have used a TPR chart for target progress report, as a lot of my data pools were from different areas. So I would have liked them to have all been in one space so that we could actually measure it over an ongoing space. And also we weren't able to get patient partners involved within the creation of the pathway. And like I said, you can't survey a patient base that are actually absconding from the hospital. So that would have been a really good input for us. But no, the project was really amazing to see the collaborative work, really in line with the Leeds ways from all the trusts, and a huge shout out really to urgent care as well. They were really pivotal in getting this off the ground and gave us so much feedback. So yeah, thank you everyone. Yeah, really pleased with it.
Great, thank you very much, Tom. Really good. And I think what's great to hear from all the presentations we heard this morning is just about thinking about how waste reduction and looking for simplicity of process can really make a big difference to both the people doing the work and those the work is for. So really great to see. So we've got a few minutes then for questions. Does any or comments from colleagues? Anybody want to kick us off? Jenny?
That was brilliant. And what strikes me about this is just the diversity of which, as you say, Phil, simplifying the process. But if you think about just the topics we've just covered, they're so diverse, and yet the fundamentals still are so applicable, which I thought was brilliant. Nicola, thank you for that work that you did with the junior doctors. And of course, if my team can now scale up what you've helped them identify with that medical staffing, medical deployment spaghetti diagram, that will benefit all junior doctors, won't it? Not just those in your team. But I was really struck by the work you did directly engaging with the junior doctors. That sounded like they really appreciated that, but you also really benefited from getting their input. So absolutely fabulous work. And I just wondered whether you had a mechanism to be able to share some of what you've done with your other medical secretary colleagues, or those that sort of manage those rotations. I just wondered whether you had any thoughts on how you might share that.
Thank you, Jenny. I haven't sort of reached out to any other sort of, because it's very rare for medical staffing coordinators to be actually in the departments. As you say, it's a lot of the time it is secretaries. But I work closely with medical deployment. So if anyone wanted any feedback, and I'm more than happy to talk through with other medical staffing to go over what we've done and the improvements that we've found by doing this. As you say, the doctors felt so overjoyed that they were actually being listened to, because a lot of times they don't get their point across. So yes, I'm more than happy to sort of reach out to anybody to speak to them and go through what we've done so far.
I'll pick that up offline with you and my team, if that's all right, Nicola. I
Yes,
think it'd be
of course.
really powerful if you wouldn't mind doing that. That was brilliant.
Yeah, of course. Thank you.
Thank you. Any other comments or questions from anyone wanting to come in for any of our presenters this afternoon? We are just at time, so appreciate people start to have other things to move on to. But well, look, if not, then can I just thank Dominique and Adele? I know you had a non-speaking part, but I know you've been really critical in the work. So well done to Nicola for the work around those rotas, and Tom around the work on the missing patients. And as I say, I think, just to reiterate, I think great examples of the methodology being used across very, very different areas, but also that people engagement and thinking about the end point around who we're actually doing this work for, which I think is really great to see. So well done to everybody. Thank you again. And we'll close Report Out for today. Thanks very much. See you next time.
Brilliant Report Out. Thank you.